So let's talk post-surgical shoulders and kyphosis. Good morning. Happy Friday. I have Neuro Coffee in hand and it is perfect. Okay. We made it to Friday. First week after vacation, always tough, lots to catch up on. So we got to dig right into today's Q&A. I had a chance to talk to Rachel yesterday. We got two questions from Rachel, which is kind of cool. So we have a post-surgical situation in regards to recovering some shoulder range of motion, and then what is perceived to be a kyphotic situation that is influencing some neck pain. So this is actually really good representation of the coherence of the application of the model, because the post-surgical situation doesn't really change the rules. We certainly have some protective phases that we have to address in the post-surgical situations, but we still apply the model the same way from measurement to the implementation and intervening. So this was a really good conversation with Rachel. She's actually really on point. So I'm looking forward to seeing what the results are after our conversation. So again, post-surgical shoulder, recapturing range of motion, talking a little bit about kyphosis and how that influences neck pain. The podcast will be up on Sunday, so be looking for that. And you guys have a great weekend, and I'll see you next week. And we are on. So, Rachel, what is your question? How can I help you?
I have a patient that's been a little bit challenging. She originally came to me post-op slap repair on the right side. She's about 6 weeks post-op now, but for the past 2 years prior to the slap repair, she's had a lot of neck pain, like almost debilitating neck pain, to where she had to stop bodybuilding training, stop a lot of activity, and the surgeon prioritized a slap tear. At the time she went through with the surgery, and now that we're 6 weeks and we're kind of getting into that more, we can start rotator cuff strengthening and getting into a little bit more active range of motion. I find that neck pain to be the most limiting factor for her. I mean, shoulders progressing great, but now that we're able to get into more, it seems a little bit more like first rib involvement. I've done a lot of whatever she can tolerate, but she has been brought to tears with even like gentle pressure. I do a lot of breath work to help bring everything down with her, a lot of breathing, a lot of relaxation. Okay. I've done some nerve glide. She responded well to that, as well as with the breathing work. I got 2 days of no neck pain after that.
Okay, well, that's
but I would just like some advice on kind of how to get everything under control so I can really progress her through this protocol and get her back.
Okay, so let's talk about some deficits. What are we still looking at from a deficit perspective with her?
Your traditional shoulder flexion seems to be probably the most painful for her, especially as we get into more active shoulder flexion.
Okay, where in the range does she experience the first element of discomfort?
I would say actively 90 degrees, passively about 120 to 130.
Okay. Now, so we got to be really, really particular here. So so she's got a strength training background, correct?
Yes.
Okay. And I'm assuming a rather aggressive one then?
Yes. Yeah. She was doing a more aggressive, like bodybuilding program.
Okay. All right. So I'm going to make a couple of assumptions here, but have you done any hip measures on her by any chance?
I have, because she has a history of knee surgery on the same side. So I checked range of motion. Hip seems to actually have really good mobility. Internal rotation was a little bit limited. Yes, I know. I was going to say.
Okay.
I wanted to be significant. I was like.
So now we're okay. Now we get okay. So this is important. This is going to be really, really important. Okay. So she's running out of internal rotation. She's running out of it very, very quickly, because chances are you've got a compressive strategy posterior that's going to be the limiting factor. So when she tries to move actively, right, chances are she's not moving away from the motion. So when you check her passively, with shoulder flexion. Number one, if you're not controlling at the elbow, then she can create some rotation through the humerus and forearm that will substitute for some of the rotation that she's missing. Okay, so if she's got any posterior compression below the level of the scapula on the affected side, what's going to happen is she's going to run out of the early phase of shoulder flexion very, very quickly. She's going to hit internal rotation. Upward rotation of the scapula is actually already occurring. So that's why she'll top out at 90 degrees actively, most likely. Yeah. So she's going to present with what we would call clinically impingement, right? Okay, so we got to get expansion in the posterior lower aspect of that thorax first. Okay. Otherwise, like I said, she hits internal rotation very, very quickly because external rotation is in this early phase of arm elevation, but because of the compressive strategy, it's out here. That's where external rotation really is. So if you're testing her through this range, she's already internally rotated. Okay. So again, posterior lower expansion in the posterior rib cage is going to get you that early phase of flexion back, and that's immediately going to extend probably where you can get her through that middle range of overhead reach.
Yeah, I could explain why I get more in the scapular plane versus that kind of traditional
always.
Space,
Well,
right?
because that's where external rotation is.
Yeah,
right?
I'm trying to get over here.
Yeah. So have you heard me talk about how you need this expansion of external rotation to superimpose the internal on? So she doesn't have external rotation in the traditional imaginary sagittal plane, right? So she can't go through here. She just doesn't have it. You move her out here, it looks great. Okay. But we want it over here, right? So you're going to have to get the, you got to get the early posterior lower expansion. Okay. And so there's any number of ways to do that depending on what her capabilities are. So you're not really in this hardcore active phase yet. So what you probably want to do is you're probably just going to maybe work from sideline to try to capture that. That'll probably be the easiest place to do it. Because again, it'll allow it to you can work even sort of like a partial rolling activity. So it's a right side's the affected side, correct?
Yes.
Yeah. Okay. So you put her in left side lying, and you can work some of the like literally taking her through an excursion of just partial rolls where she's going to create the expansion as she rolls in one direction. She'll create the compression in the other, and you just take her back and forth that way. You could probably drive some are you familiar with like scapular PNF patterns and things like that?
Yes, I've been trying to go through that PNF.
Okay, yeah, but don't forget about the pelvis, because we know that she's got the deficit in the pelvis as well. So the pelvis and the thorax are going to behave very similarly. So if she doesn't get expansion in the pelvis, good luck trying to get it in the thorax. Not going to happen. So some of the measures that you're going to want to pay attention to then are your ER measures on the same side hip. So if you put her in left side lying and you check hip abduction, you've got a limitation there, or you can't even get her into the appropriate position for the measurement. You got some issues there that you have to address. Otherwise, you're not going to get them in the shoulder. This is one of the reasons why we run into pickles with these post-surgical patients, because people look at they sort of zero in on the area that was affected, not recognizing the fact that the whole axial skeleton is an influence here, right?
Yeah.
Make sure you're not neglecting the lowers. Okay. It'll help you every time. It will help you every time.
And at least I can have something to do with her that's not breaking protocol and not kind of putting her at risk upper body wise.
So hang on, think about this. So you're still in the protective phase of this right shoulder, but you've got a left extremity, you've got two lower extremities, and the rest of the axial skeleton and her neck, because we know that we've got an influence there as well. All right. So when you think about end range shoulder flexion, so here's what we need there. We need the upper thoracic spine and the lower cervical spine to be able to turn towards the same direction. So if you're checking traditional shoulder flexion in the imaginary sagittal plane, you better have a neck that can turn that way, because if you don't, there's no way that she's ever going to get the end ranges comfortable.
Yeah, she cannot turn to that direction. And a lot of it's like pain limiting and like
okay. So there's a lot of stuff to do here. Okay. So as you're working scapular PNF activities, what I would do is I would look at it from the perspective of I'm trying to turn that lower cervical spine. So you're trying to create dorsal rostral expansion when you're doing the scapular PNFs, because that's going to start to turn the lower cervical spine in the same direction. And this is all kinder, gentler stuff. So you superimpose your breath work on top of the scapular PNFs. And then eventually she can sort of take that out of your hands, and then she can start to reproduce it. And now you've restored the active cervical strategy that she's going to need to be able to reach up overhead. So there is so much you can do with these post-surgical patients that are within the surgical restriction, right? That people just don't appreciate. It's like, you just got to look at all of these segments and how they influence the outcome of the affected joint motion, right? Okay. It all works together. It all works together.
Yeah.
Right.
Thank you. Yeah. Because you just feel so stuck post-op sometimes. And it's almost like sometimes when you're with the patient, it's like almost overwhelming. And especially when they're emotional, like she'll get so emotional and frustrated with where she's at that I'm just trying to do a lot of gentle things in different areas. So you can give her more things to do. So she sounds like it's kind of like the go-getter, type of hardcore trainer. It's like, give her more things to do. Help her to recognize the fact that, hey, you know what? I need you to drive this left side. So think about this. So you can't do active things on the right side to drive this dorsal rostral expansion or the posterior lower expansion. But if I create a compressive strategy on the back left side, I get expansion on the side that I'm trying to get it in the first place. Yeah. So don't forget about the influence of the left side mechanics affecting the right side of the axial skeleton. Huge, right? Take every opportunity to create the orientations and the muscle activity on the other side. Like I said, tremendous value in that. Okay. Yeah, you got a lot of stuff. You got a lot of stuff you can do here. Okay. Perfect.
Yeah. Don't let your protocols interfere with your ability to be creative in the clinic, because there's, like I said, there's so much you can do. You don't have to drive that shoulder to create the expansions that you want.
Yeah.
Right? It'll come.
Yay.
What else can I answer for you?
I actually quickly have another cervical patient, much older. She is hyperkyphosis and in the thoracic region, increased lordosis cervical wise. Same thing, having lots of like debilitating neck pain, but she's that different situation where she's just like so expanded in the back. She's also, all of her pain is on the right side, and little history, she also had a bilateral mastectomy.
Okay.
And she had complications on the right side.
How long ago?
5 years ago.
Okay. When you say complications, was it like lymphedema or something like that? Or was it something else? Did she have radiation?
She did have radiation.
Okay. Did she have like a soft tissue scarring that's okay.
Yeah.
All right. Yeah. So this is a toughie, because you've got scarring that's going to create a limitation in the ability to expand, and expansion is where you're going to capture range of motion. Now, it doesn't change the rules as to how you're going to approach this. It's just going to change the constraints, and then it might impose some limit on the amount of change that you can make. But the rules are the same. So just like we were talking about the female with the shoulder, with the post-surgical, you're still going to try to drive expansion. Now let me talk to you about this kyphosis thing. Under most circumstances, what you're actually looking at is a compressed upper thorax. And so it might look rounded, but what it is she's bending herself forward because she's trying to create a space to get air in the upper thorax. So the upper thorax is actually kind of flattened. And then especially when you see the lordosis, that it looks like it goes from the sacrum all the way up into the middle thorax. You know what I'm talking about?
Yes.
Yeah. So what she has is she has a bend in the thoracic spine that'll probably have the apex really close to the inferior angle of the scapula, because she's compressing the scaps against the upper thorax, right? And so she creates that little bit of space. So she pulls her sternum down in the front, okay, and she creates a little bit of space in that posterior aspect of the thorax, and that's actually her inhalation strategy, okay? So you're still going to try to drive dorsal rostral expansion, and you're going to try to drive up pump handle. So the amount of manual work on the rib cage is now going to come in really, really handy.
Okay.
So you can use upper extremity positions to help create some of the expansion. So you think about like an overhead reach, and if you can think about a scapular position and how pec minor would attach to the rib cage. So you got ribs 3, 4, and 5 that pec minor is attached to. So if I can move the scapula into that what would traditionally be considered like a posterior tilted kind of a position, it's going to help pull those upper ribs up, which is going to bring the pump handle with me. Okay, so that's going to get me some of the anterior expansion that I need to bring her up out of this pulled down position. Then I drive traditional dorsal rostral stuff. So have you seen some of the dorsal rostral?
Yeah, I use that all the time. I love it.
Yeah. Isn't that money? I just love that exercise.
I do. It works wonders.
It's great. It's great. Don't forget that on your post-surgical patient too when the time comes. But so again, so I need to make a little bit of room. I need to be able to get her into a better position so she can execute the other activities. So again, let's think about bringing that pump handle up. Try to reduce some of the rectus abdominis that she's using on the front side too. So again, some of your rib cage work, and then again, if you're superimposing the breathing like you said you were on the previous patient, you got to start to drive that too, because that's the only way that you're going to create the expansion from the inside out. Okay. So I think you just kind of have to reverse gears on the superficial strategies that she's using. So again, reduce the rectus abdominis that she's using. Again, it's an inhale strategy. So what you're going to look for is get her into a comfortable position and then teach her how to capture this non-compensatory inhalation, right? So you support her head as high as you need to off the table. You teach her how to reorient the pelvis. So again, we're going to use the pelvis to drive mechanics upward. So don't try to force things in the upper thorax to move. Let's encourage them to move, and then use the extremities to drive areas of expansion through the rib cage.
Okay.
Right. Yeah. So again, your PNF patterns come into play again, because that's going to help us drive that superficial musculature and allow you to create the expansion where you need it.
Okay.
Does that make sense?
Makes sense. Yeah.
Yeah.
No, it makes a lot of sense. I think I just got so distracted by that hyperkyphosis that it's almost like you don't think of it as a compressive.
So I don't even call it a kyphosis anymore, because I don't like the term because it's vague. Somewhere on my Instagram, there is a thing called the Terry Project.
Oh, I was looking for that because
I thought so. This is the scenario. This is the scenario that you're actually looking at.
Yeah.
Okay. And so what we did with Terry, it's like Terry came in and he actually got taller during treatment, which was really, really cool, because he had a physical, and he says, I'm 1.5 inches taller than I was last year. How's that even possible?
Yeah.
Because we brought him up. But what he had done was a bunch of scapular muscle exercises in an effort to actually fix his posture. And what it did is it created the compression that drove him downward, right? So we just had to reverse gears. So we did a lot of rib cage mobilization. We did a lot of breathing to start to create the anterior expansion, which allowed him the capacity to release this anterior superficial musculature. Yeah. And allowed him to become more upright. And then we worked the dorsal rostral expansion.
Okay, thank you.
You are very welcome. You're very welcome.
Thank you so much.
Right. Let me know how it goes with your people, okay?
Thank you so much. It was nice.
You're very welcome. Have a great day.